We're down to it's an in-person tutorial.
I love it.
But hey, welcome back to our Jumpstart Live session. I'm Dr. Sean Burke, as you know. This is Dr. Vanita Tandon, which you also likely know. And we had two questions come in, which we can try to address first, and then we can see if we get any others. Everybody knows about our promotion currently running, so we'll go to the questions. So let me go with the second question first. It was a question around cottage cheese and whether we recommended low fat or full fat. And the answer is a little bit of an it depends, both on personal choice and then, as you've heard expressed before, on this notion of degree of insulin resistance or carbohydrate sensitivity. And for this individual whom I looked up, you have some signs of carbohydrate sensitivity for sure. That's true in terms of waist circumference measurements, which has been over 40 in a man, which is defines part of this kind of central adiposity or visceral adiposity concept. And now pretty dramatically improved from where you were about a year ago, with a 6-inch decrease in waist circumference, an improvement of percent body fat from about 36% to around 28%. Pretty dramatic reduction in fat mass of around 25 pounds, despite losing almost no muscle mass. So all of which is great metabolically. That helps improve arguably underlying insulin resistance to drive you closer to insulin sensitivity. Now, in your case, I think I would say, and by the way, your LDL, which is another thing we potentially worry about vis-a-vis trying to individualize your recommendations for saturated fat in particular, your LDL looked great. It was around 115 when it was last tested, with a cholesterol HDL ratio of 3.1, which is really close to what we think of as the optimal range of under 3. Similarly, you had no suggestion of fatty liver on your liver tests. You had great triglycerides, 76, and an HDL of 62, making that ratio of triglyceride to HDL kind of suggestive of a lack of insulin resistance. Actually, great looking cholesterol panel actually too. You had this one sort of bizarre elevation in fasting blood glucose that was really mild and not that significantly changed from before, of a level of around 102, with an hemoglobin A1C of totally normal at 4.9%. Dr. Tandon, I don't know if you have thoughts around that, but it's interesting. When I see that kind of a picture with this really mildly elevated fasting glucose, which is technically pre-diabetic, but without other signs of the metabolic syndrome, frankly, anywhere else in your lab panel, except a history of hypertension, which is relevant, and an elevated waist circumference over 40 inches. I kind of downplay that elevation in fasting glucose just because it's one marker, but the rest of the markers look pretty good, again, with the exception of the elevated blood pressure and the elevated fasting glucose. So
Yeah, I agree. It's kind of a moment in time, that one glucose value, which could be affected by a whole host of other things.
yeah.
So if it's repeatedly elevated in that range, then that's different. But like you said, if it's just a kind of a one outlier,
Yeah.
It could be due to other things.
So were you expressing more of that insulin resistant pattern? We would try to push you even harder towards a lower carb, higher healthy fat approach and encourage you really to eat whole fat based cottage cheese, which is where this question kind of began. Should I have 2% low fat or 4% high fat cottage cheese? Honestly, the difference between those two, both in terms of carb content and frankly in terms of fat content, it's like a 20 calorie difference. it's really modest. And so I think it goes back to the idea in your case being a little bit in the gray zone again. Some suggestion of insulin resistance by blood pressure, by waist circumference, but not much elsewhere. But really, what's your personal preference? Even low fat cottage cheese is relatively low carb, and it's quite high protein relative to the carb content. So, I think that's kind of a personal one. And, depending on how you feel about it personally, pick the one that you like. We have encouraged people not to consume non-fat dairy products, Greek yogurt, cottage cheese, partly because um, there's often additional carbohydrates added to them to make them taste richer when they take the fat away, and partly because, again, conceptually, as you've heard on many of these webinars and even the Gary Taubes interview, which I thought was really interesting, vis-a-vis this concept that, hey, it's insulin that's really making you accumulate fat, and it's dietary carbs that are driving insulin to force that fat accumulation. Anyways, that's part of why we're trying to get people away from this notion that, gosh, I should be eating non-fat products because of a caloric equation. We want you to think in a weight loss in more of a biologic equation. How do I reduce the hormone insulin that's the principal regulator of fat metabolism, than a pure caloric question, which ultimately will kind of go on to the next question, which we can address in 1 second. But anyways, love cottage cheese. Great low carb option. In your case, I would say pick the one that you prefer. Don't fear the high fat version versus the low fat version, and just pick the one that seems better for you. You don't have anything on your lipid profile that should get us to worry about restricting fat. The caloric difference between the two is not very big. The satiety difference between the two may be big enough to actually make a good difference for you. And just pick the one you'd enjoy the most. And I would say don't worry too much about it.
And isn't pre-mixed with fruit.
Well, yeah, no, it's interesting. Cottage cheese versus yogurt, they don't often add a lot of sugar, which is a pretty big difference. And actually one of the reasons I think cottage cheese is actually a great option. The protein to carb ratio is a little higher. And it doesn't, you kind of avoid that added sugar concern.
Yeah, exactly.
So hopefully that answered that question. There was another one I saw came in. So let's see. Oh, awesome. So glucose down to 97 versus that sort of aberrant one that we had at 102. That's even the glucose that you'd done before that, I think, was 95. So you're in kind of the same zone in all three of those tests. And the most important thing is we don't see it trending up. And then your A1C is, previously stated, is at a really nice place at 4.9%. That's great. So hopefully that answered that question. And then we can try and move on to the next one, which was, hey, how does one figure out how many calories to eat in a day and not gain weight? Exercise included, question mark. And similarly, in this case, I went to the person's chart and tried to kind of look at their specific situation. So I'll describe that a little bit. This is a 65-year-old menopausal woman with a weight of around 162, currently at a very healthy BMI of 23, challenged by getting her quote-unquote cravings under control at times. Similarly, great set of labs. Her hemoglobin A1C had been 5.4%. Now it's 5.2%. Fasting glucose in a normal range at 90. HDL and triglycerides also beautiful. And HDL in the optimal range of over 75, hers is 84. Triglycerides in an optimal range of under 100, hers is 44. And her cholesterol to HDL ratio also in a beautiful range of 2.5, so under 3. Totally normal liver test, so no signs of fatty liver disease. So a healthy metabolic profile in this person, had a weight of around 162 in a menopausal state. So what could be, beneficial? First question was, how many calories should I consume? Well, we're going to assume this person, weighing about 162 pounds, burns about 1,600 odd calories a day staying alive. Yes, we're trying to say get away from the caloric equation, but at the same time, we're trying to say, well, there's probably some benefit to that, or some validity to the notion that it is beneficial to take in less energy than you're expending staying alive to kind of catalyze harvesting of your own internal fat reserves to lose weight. So typically for our member or patient population, we'll try to induce what's somewhere between a 500 and an 1,000, or sometimes even closer to 1,500 calorie per day deficit. You're taking in less than you expend. So in her case, 1,600 odd calories a day staying alive, if she's in the 800 to 1,000 calorie per day range, that's a really good goal. And it doesn't mean that that's the only calories she's burning so that her metabolic rate drops to meet that. Just the opposite. We want her to consume that level of caloric intake, but in a way that minimizes her insulin levels and then liberates her own internal fat reserves for two reasons. One is then she's going to get the calories that she needs, the energy that she needs from her own internal fat reserves. So she's burning 1600. She's going to burn the 1600. She's just going to burn it between the difference between the 800 that she took in or 1000 she took in and the 1600, give or take, that she needs. She's also going to help minimize cravings for carbohydrates by minimizing those insulin levels, liberating her own internal fat reserves, and creating steady fuel flow for her brain. So that, that's the whole challenge of becoming a fat burner. And one of the great benefits of becoming a fat burner, you no longer become dependent on carbohydrate for fuel. And people tend to move away from what that, David Ludwig, as you've heard this probably quoted before, quoted as an always hungry state, to a state where people are actually almost really voluntarily eating less calories because their always hungry state goes away because their brain has a steady flow of fuel. So hopefully that makes sense. If it doesn't make sense, I would recommend going back to that health webinar we did with Gary Taubes, because I thought from a physiologic point of view, I thought he had some great graphics and explanations around how insulin minimization, improvement of insulin sensitivity over time, helps to drive weight loss, helps to minimize hunger and cravings, and for many of our patients, helps to reverse metabolic imbalances, which again, this person isn't expressing. Another thing that is related to, Dr. Tandon's service bioidentical hormone replacement therapy is menopausal women also struggle with weight gain and changing the shape of their body to have more weight around their rump and their belly, as again, a hormonally induced physiologic change. And so there could be, and I'm going to ask her to address this in a second, but anyways, there could be some benefit to hormone replacement for her. That could be true on estrogen, progesterone, could also potentially be true on thyroid, where her thyroid level, while not abnormal, was what we would argue kind of suboptimal. And if she had symptoms to match that suboptimal thyroid level, there might be some benefit to treating that too. So, yeah.
Just to kind of dovetail on that, the estradiol, when that declines in menopause, has a direct impact on metabolism. We used to think, oh, women age, they gain weight because they're less active, maybe they're just sitting around more, but that actually is not true. Estrogen itself has a direct impact on belly fat and metabolism. So definitely when we kind of optimize that again and restore it, it helps women change their body composition again. So they lose that belly fat, their metabolism improves. And then, like you said, thyroid's the main metabolism regulator. So if that gets optimized, that can also help.
One thing that our study showed that was related that frankly surprised me, anecdotally, I thought the menopausal women were losing weight at a slower rate than other groups across Jumpstart. And what we found was that really wasn't true. As a percent weight lost, they were losing at the same rate as the perimenopausal and the premenopausal women.
That is surprising.
Yeah, it was surprising, and we see that in clinic, and we have people in older age groups, define how one would like to do that, perhaps. But losing great amounts of weight quite effectively, and
and is that because we're optimizing their hormones, or that's independent?
That was independent because this was all 2007 to 2017. So no hormone replacement embedded into that data really.
Interesting.
Not much. So yeah, that was surprise finding for sure. I always thought that was one of the headwinds that people were facing, and their results are just as good as the premenopausal woman.
Right.
So the other follow-up question to this was, in terms of figuring out how many calories to consume, again, is exercise included? And I guess I would go back to that notion of, if you minimize your insulin levels enough, you can exercise and you're still going to access what you need through your own internal fat reserves. So I don't typically add quote unquote calories to people's diet based on their exercise. There could be exceptions to that when it might be more extreme. But in general, that's not something that I feel like is necessary, particularly if symptomatically they're feeling good. And we can always fine tune if needed, but it's not something we add as a protocol per se. we also generally find exercise to be a great tool for body composition improvements and mental health and metabolic health and all these wonderful things, but kind of a lousy tool to help people either lose, or I would even argue maintain weight loss. So
Sean, do you ever have people measure their basal metabolic rate, using those equations or the CO2?
we're mostly doing it through that sort of weight in pounds times 10 approximation, and then using the InBody machine, which will also produces a basal metabolic rate. So those are the only ways we're doing it at present.
Okay.
Um,
I know there's some outfits out there that are, marketing that you come and get measured, and I don't know what
yeah,
it costs, but
I mean, we explored one where you breathe into a tube, and I think it measures, I think it's CO2, but
yeah.
trying to get your basal metabolic rate. And to be honest, yeah, we never implemented it, but it's an option that's out there potentially downstream.
I don't know the validity of it either. I'm just curious.
Yeah. So let's see if any other questions. Doesn't look like there's any other questions. If anything burning comes to mind right now, speak speak now or forever hold your peace. Um, and otherwise, this Thursday, Dr. Tandon, which you're doing a webinar on.
That's testosterone in women.
Oh, great. That's a fascinating subject. So that'll be great. And otherwise, we'll be back next Tuesday if you have any other questions you'd like addressed. So thanks for joining us today.
Thank you.
And have a great week, and hope to see you on Thursday.
You too. Bye.
Take care.